أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب زدني علما رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear friends, fellows, students, and my colleagues who are interested to learn and to study or repeat how to report the X-ray chest. So I have done 9 sessions previously on the chest radiology in tutorial forms, and then I am going to report some cases, refreshing it. So 4 cases or 5 cases has been discussed previously. This is X-ray chest number 6. Now this is a case of 50-year-old hookah smoker lady. In our villages and in some part of our Pakistan, ladies are addicted to, or you can say habituated to, smoking with the hookah. And in their mind, that the hookah, this is a digestible type of a thing. It increases the digestion of the system. So after meals or many times of the day, they took hookah, and they said it will push the contents of the food you have taken, and it got the what is called in our language the prokinetic effect. So this is a misnomer, this is a myth. A smoker lady, hookah smoker lady, known case of chronic obstructive pulmonary disease, experienced sudden left-sided chest pain associated with shortness of the breath while she lifted 40 kilogram gehun bag or atta bag or wheat bag 2 hours back. So ST is very short. Sudden left-sided pain associated with the shortness of the breath. Here, up till here, it is possibility of what is called as the acute coronary syndrome. It may be possibility of the what we called is the dissection of the aorta. It may be prolapse of the disc. Possibility of these are there. The shortest history. She brought to the A&E where X-ray revealed temperature 97, pulse was 122 per minute, it is tachycardia, low volume pulse, irregular, means that it has definitely either the patient has developed the atrial flutter or fibrillation, or multifocal type of atrial tachycardia, or multifocal type of the PVCs. Irregular. BP 190 by 50, lower, it is lower down. Temperature is lower down, BP is lower down. Central cyanosis was present. Trachea was shifted to the right side of the pain occurred on the left side. Restricted left-sided chest movement on that side with bulging of that area, and the tympanic, very, very hyper type of resonant percussion notes all over the left side, and no breath sounds were audible. Apex beat was also not palpable on this occasion. These are the findings on the A&E where the medical officer examined this patient. I hope that the medical officers or the casualty medical officer do these type of examination. I don't think so they are doing. Investigations are hemoglobin 17 gram. It is definitely erythrocytosis because she has got hookah, smoker, and TLC 7600, no infective content. Platelets is 4,30,000. It means that the acute phase reactants are in action. Reactive thrombocytosis. ESR was 40. In our settings, 35 up to 30, 35, I'll take normal of a 50 years old lady. So it is not much higher. I don't think so it is much higher. The random blood sugar is 155, and ECG shows you low voltage ECG with irregular rhythm and with no P waves, plus non-specific STT changes. They are not specific. In order means that the lateral wall leads or the anterior wall leads or the inferior wall leads are not coinciding with each other, plus RX, right axis deviation. Axis was, in this case, was 100 plus 160, 170. Cardiac enzymes were unremarkable. Cardiac specific troponin after 1 hour and after 2 hours was not positive. It was not positive. X-ray test was done on this occasion. Definitely it is a very important investigation as a routine and presented to you now for reporting. You report this X-ray now. I am reporting it for you that the requirements are fulfilled or not. It is PA view, yes, it is PA view because the vertebral column, the intervertebral spaces are not visible fully at all. Suprachoroidal fossa dilated. It is a frontal projection, dominant PA view. Patient was S, means first S. He was straight. Look the spine. Here. Draw a line there. He is straight. He was straight. Then he was standing. Why? Because first rib, this is the second rib count, third, fourth, fifth, sixth, seventh. Dome of the diaphragm. It means that he is in the erect posture, not in the sitting posture or decubitus posture. And third was that he should be still, means that deeply inspired and hold the breath properly. He deeply inspired because look the rib this there. It's 8th or 9th here. Fully inspiration has been taken and hold the breath properly. How you say that he has hold the breath? Because of the bronchovascular markings, they are visible on the right side very clearly. Coming to the next point, the bony skeleton is there. This is the first, this is clavicles, the first rib, second rib, upper border, lower border, upper border, lower border, upper border, lower border. Now here you see that at the mid-clavicle line, a vertical line is drawn here to measure it. It is about 2.5 centimeter. So it is neither it is obstructive type of a nature of the disease, nor it is restrictive type of lung disease. And then the scapulae, medial border. The medial border is not visible. It is with the isodents with this. It means that he has properly done this X-ray. Cervical spine, intercostal spaces. This is the spinous processes. The other one, it is not seen. The transverse processes are not seen. No cervical rib was appreciated. No accessory rib. Then afterwards, the soft tissue shadows here on the lateral wall, below the diaphragm, and in the upper part of the neck, here in the neck area, and in this part, below the sternoclavicular joint. This is the part. The soft tissues are there. There is nothing significant. Trachea. The trachea will be described like this. This is a tracheoidogram. It's moving like this. It is going like this. Look my cursor. 10 degrees towards the right side is normal. More than 10 degrees is abnormal. It is deviated on this side 20 to 30 degree. So there is a displacement of the trachea to the right side. Look here it is all okay. But lower down, up till here is the trachea, going like this. This was the direction. Although not much appreciated, but I can see this. Then afterwards, about the lung fields are concerned, comparison should be done between the apex with the apex, first interval with the first, second with the second, third with the third, fourth with the fourth. In this fashion, the lung fields are divided for the study purpose. At the level of the second intercostal cartilage, I will draw a line there, a horizontal line. And the fourth rib, I will draw a line. So right side is upper, right middle, right lower, left upper, left middle, and left lower. Now comparison after comparison, I have seen that although this part, only see this there is slightly haziness and these are equal. But on the comparison of this side and this side, there is hypertranslucency. There are no bronchovascular markings are seen. Two things are normal in the lung fields. One allogram, second is bronchovascular markings. In this side of hemithorax, left hemithorax shows there are no bronchovascular markings at all, zero, and at all. This is actually what is you see here is the lower border of the breast shadow. Do not confuse it. So this absolute hypertranslucency is seen. The apex of the heart is here. It should be on the metaclavicular line here. So, because of the air in the pleural cavity, what do we call is pneumothorax? It's a spontaneous pneumothorax and it's pushing this middle mediastinum to this side. Shifting of the middle mediastinum is there. Aortic knuckle is here. It should be here, very near to the junction of the clavicle, or very near to the clavicle, junction with the medial 1/3 to the lateral 2/3. It should be here. So all is shifted here on the right side. What is important to see here, this part, look, this very, very small lung margins are visible here. This is the collapsed lung. Because of the push effect, the lung was collapsed. The lung margins are visible of the left lung, here, here, here. If somebody can detect it, it is very good, this part. Otherwise, if you cannot, no problem. The middle mediastinum was shifted. This is very important. And because of the push of the high pressure of the air in the pleural cavity, the dome of the diaphragm here is flat. It is not like this. Flattening is seen here, lower down, on the left dome of the diaphragm. Right dome of the diaphragm is fine. It is curved, is normal. The cardiophrenic and the costophrenic angle are clear. Here again the costo and the cardiophrenic angles were clear. About the middle mediastinum, because it is pushed middle mediastinum, it is difficult to describe. The lower part of the middle mediastinum, the size seems to be normal, although it is pushed. And the shape is this one, it is the left border, this is the right border remaining. See, the upper part of the mediastinum is this, is divided into four. By learning purposes, I divide it into four. The first, second, third, and fourth. First will donate what? The ascending aorta, the second, and the third, the arch of aorta, and the fourth one here is indicating the pulmonary conus. So pulmonary conus is normal. So there is no associated pulmonary hypertension in this case. And then we see because the lung is here, it is coinciding with the border. The remaining part of the lung, which is collapsed lung, it is intermingled with the border. It is obscuring this border. This is a sellout sign. Some pathology in the lung parenchyma was there, which is obscuring the borders of the middle mediastinum, either the lower part or the upper part. The sellout sign is present in this case, and the highlights remaining of the left side is there. It is obscured by this. Right hilar, this is the stem, this is the upper part, this is the lower branch of it. It is, coming out from there. It is normal one because it is overactive. Lung is overactive because compensation for this patient, for the survival, is this lung only remaining. 50% is gone, 50% is working. Patient was sinus, that's why, central sinuses. Because of the push of this middle mediastinum, there is evidence of atrial fibrillation again. So he is in a respiratory distress now, I would say. And it will go to the respiratory type 2 failure if intervention is not done properly. So my conclusion is this: the trachea was shifted to the right side, and there is the hypertranslucency on the left hemithorax. There is no bronchovascular marking visible at all. But all aerograms and anograms are there. The remaining part of the lung parenchyma was appreciated. The dome of the left side is down, it's flat, and the middle mediastinum is totally shifted to this side, on the right side. This is my conclusion. So the differential diagnosis again, it may be acute inflammation or the complication of acute inflammation, chronic inflammation or the result of the chronic inflammation, tumor and tumor-like state and its complication, allergic conditions, and the other one, the pneumoconiosis and the idiopathic like sarcoidosis and the parasitic infestations, all will come. And then you will definitely, the diagnosis exclusion was done. The patient was known as asthmatic. So she has COPD. Probably the rupture occurred of the impulsiveness bulla, probably. And it has caused because she had lifted weight and the impulsiveness bulla ruptured and causes this what is called as the spontaneous pneumothorax. This is my conclusion. The inference is this: either I will deal myself or I will refer. If I refer, I will refer to the pulmonologist. This is a medical emergency, dire medical emergency. If I am dealing with this patient, I will put a needle where the maximum hyperresiliency will be found. I will do it because all gases are going up. So I will put the needle on the upper side. Just I will put a needle and leave it. All air will come out from that needle. A wide bore needle was put at the mid-axillary line here, or the posterior axillary line. Patient will be relieved much. There is no need of local anesthesia because patient is already in distress. You will put the needle and air will leave, followed by what we'll do is, in this patient, is that we will go for the underwater seal. If anything is coming out, bubbling in the water, we'll put for the 3 to 5 days. There is no bubbling is seen, and a repeated X-ray shows the expansion of the lung. We will remove it and we will seal it properly where the wide bore needle was put. And then we investigate further what was the cause. I'll do all the other investigations, the sputum AFB. Along with it, I will do the HRCT, I will do the ABGs, LFTs, UC, all investigations. to rule out any other associated pathology which can cause the spontaneous pneumothorax. There are many causes of pneumothorax, traumatic pneumothorax, it is maybe spontaneous pneumothorax. This is called tension pneumothorax. Tension pneumothorax is the spontaneous pneumothorax which causes the mediastinal shift. Tension pneumothorax is the spontaneous pneumothorax which causes the mediastinal shift. So this is the definition of tension pneumothorax. You go for the etiology. Most probably it is COPD, infected in the bulla, which was ruptured. Most probably, but other causes should be excluded. And last question of mine for you is, what is the condition in which the repeated pneumothoraces are seen? In expectation of the repeated pleural effusion, no pleural effusion. But repeated pneumothoraces were seen. What is the condition in the world? This is the question which I have given to you. Answer my question. If you answer, I will be very happy. I will come, inshallah, with the next case and report it. I hope that you have enjoyed it with my reporting. I am highly thankful to you for the listening. Subhana rabbika rabbil izzati amma yasifun. Wassalamu ala al-mursaleen. Walhamdulillahi rabbil alameen. Wa ma alayna illa al-balagh. Assalamu alaikum wa rahmatullahi